That should be us then. Good evening, everybody. Lots of you joining our first ever Monkeypox Live. Quite a brave move, I think, on behalf of Public Health Scotland, NHS colleagues, and my third sector colleagues to come together to try and share as much as we know about the situation as it is, and the upcoming vaccine and the rollout. My name's Mark Kelvin. I'm the Chief Executive of a charity called LGBT Health and Wellbeing. We're joined by colleagues from across the NHS and Third Sector this evening, and we'll be taking questions a bit later on after we've got some information for you. For a start, I just want to set out some parameters to keep us all safe and to keep this a safe space for us to ask any questions that we like this evening. There's that old adage of no such thing as a daft question, and to make sure that we all feel safe enough to be seen, be heard, not physically, so it's all right, you're off camera, but to be ourselves and to go away with all of the information that we came here to get this evening as much as possible. So in order to keep ourselves safe, we'll ask that if you have a question to ask, at the bottom of your screen there, you should see next to the chat box, there's a window for questions and answers. Just type in any questions that you have just there, and as they come to you, and we'll deal with those at the end. Similarly, if you're comfortable typing in questions or asking questions after all of the presentations, we can take some live as well. Because we're coming via the platforms we're using this evening, there is a minute delay, so please forgive us. We're not ignoring your questions. It might just take us a moment to see them. In terms of respectful participation, hopefully it won't happen, but if anybody joins the call, or if anybody intentionally or unintentionally makes this space feel less safe for anybody this evening, then what we'll do is automatically remove you from the call. If that does happen, and it is unlikely, myself tomorrow will just reach out and explain why we did that, and give you the opportunity to have a conversation around it if that feels appropriate. Similarly, there's over 20 of you on the call this evening. We will try and create an equal airspace. So if we feel that you've asked a few questions and there's somebody who's not had the opportunity to get to one yet, we'll field it in that way as well. But we'll follow up your question again, either later this evening or tomorrow. So for the session this evening, we've got a quick introduction from Dan about what is monkeypox. We'll talk a little bit about the epidemiology, what happens if somebody gets monkeypox in Scotland. We'll talk about the vaccination programme, and with the delay in vaccination, or delay until each individual can be vaccinated, we've got some advice on prevention until vaccination, and as well as some final information on where you can get existing sources of information and support until it's your turn for the vaccine. So that's it from me. I'll be back at the end to answer any or facilitate any answering of questions. We're going to go over to Dan now for a quick introduction about monkeypox. Thank you.
I'll mute Dan.
Hi everyone, I'm Dan Clutterbuck. I'm a GU Medicine and HIV consultant working at the Chalmers Centre in Lothian. My pronouns are he and him. I've got no conflicts of interest in with regard to monkeypox, and I've got some slides. I think the first thing to say is I think quite a lot of what I will say will be familiar to some of you. Possibly there'll be something new. I will be keeping it basic, but if I do slip into medical terminology, as Mark said, there's no such thing as a stupid question. Please put in the Q&A. If I've used something that is impenetrable, if that's the case, it's unintentional and we need to come back and explain it. So I'm still waiting for some slides, but great. Lewis is moving on slides. So we're on the real basics. So what is monkeypox? Next slide. So what it is, it's a virus which is related. It's in the same group as chickenpox, which I suspect everyone's familiar, and smallpox, which was eradicated in 1980. We stopped vaccinating people in the 1970s. So it was first discovered in some macaques, some research animals in the 50s, but it was first described in Africa in the 70s, in West Africa in the DRC, and there are two parts of Africa, a central part in Nigeria, where two different sorts of monkeypox are what's called endemic. So we're used to seeing outbreaks of say 20 to 80 or 90 cases. And it's something that jumps from wildlife to man. Everyone's getting more familiar with that idea. It happened with HIV in the 1920s, and of course it happened with COVID in the more recent past. It looks like, although it's not absolutely clear, that it's mostly in rodents, and we're used to this infection being seen in West Africa and seeing literally the odd case in places like the UK associated with travel. There have been some outbreaks. It linked with animals. It got into a prairie dog population in the United States, and there were some cases in the US earlier in the century, but we've not seen masses of it. Next slide. So as a result, we didn't know all that much about it, but thinking about how it's transmitted, it's skin-to-skin contact and droplets. It's not absolutely conclusive, but there's a lot of evidence to suggest it isn't airborne. Now, there were loads of questions about this that some of you no doubt be familiar with. We discussed it at length about COVID, but I think we can be pretty confident that it is not airborne, but there is some droplet spread. We call it a sexually transmissible infection, so it's not only through sexual contact, but often the skin-to-skin contacts involves some sexual contact. We see loads of monkeypox DNA when people are inpatients, when they're looked after in hospital, on all the hard surfaces in the bedding, and it's really, really resistant. It's resistant to drying out, and it lives a long time, but slightly surprisingly, with very little evidence of accidental spread. So very little evidence of spread through social contact, very little evidence of spread through medical care, no cases of somebody acquiring it through caring for somebody with monkeypox in this outbreak. We've got one confirmed, just very recently published, I only became aware of it this morning, case of someone transmitting monkeypox to a pet dog. New slide. So who's affected? Again, it may not be a surprise that the majority of recent cases has been very well publicised, affecting a population of gay, bisexual, and other men who have sex with men. In particular, we see that people who've had monkeypox are more likely to report having multiple partners, having group sex, using sex on premises venues or saunas or sex parties, and they seem to be much more likely to be affected. We are seeing gay and bisexual men who don't report these behaviours presenting with monkeypox. In some cases where there isn't an explanation, we're seeing much fewer cases in men who don't report same-sex behaviour and in cis and trans women. In fact, there's only been about 30 cases in women in the UK reported. New slide. So what happens? Well, the incubation time, so the time between contact and symptoms, is usually about 12 days. The spread's shown there. Most people feel what we call malaise. The posh word is malaise. We all know it as feeling a bit shit. About 60% of people get fever. Some people get muscle ache and joint pain. It's fairly common to get enlarged lymph nodes, particularly if it's been sexually transmitted in the groins. But nearly everybody gets rash. Really importantly, and what we've found in this episode is about a third of GBMSM with monkeypox get some inflammation of the anus and rectum, so maybe some discharge and significant pain, and about 10%, that's what they present with. Nearly everybody manages to manage their monkeypox at home without any specific treatment, although about 10% of people are admitted. Next slide. This is a picture of the skin lesions. There are many more graphic pictures of skin lesions out there. Next slide. Don't need to go into detail, but the most important thing, next slide, to say about this, next slide, about the rash is compared to chickenpox. Monkeypox rash tends to be what's called centrifugal, so on the face and the palms, rather than chickenpox, which tends to be on the trunk. Next slide. And when very recently a group of clinicians and scientists looked at 500 cases, they were seeing rash around the anus, on the body, less commonly on the face and the palms and soles. The number of lesions is really variable. Many people have 5 or 10, but a small proportion of people have hundreds. A few people, about 10%, got a single ulcer, and that sometimes has led to some problems with diagnosis because it can easily be confused with another STI, for example, syphilis. A lot of people get lesions in the mouth and around their anus. Next slide. If you do want to find out more and look at slides to make you feel uncomfortable, showing pictures of people's lesions, those are the two most recent papers with the pictures. They're all open access. I've put the easiest way to find them by Googling those simple phrases, so you don't need to use the links. And just to note, I'm not sponsored, so other search engines are available. Next slide. So we'll go into this in a bit more detail, but the main things to know is if you're diagnosed with monkeypox, you're advised to isolate at home. A few people need admission. That's not usually because they're in danger, but it's usually because they've got pain, often rectal pain, or in guys swelling of the penis. A small number, and I really do mean a small number, have had infection affecting the brain, the lungs, or their eyes. There are specific antiretrovirals, but these are only given in a few cases, and there are trials planned and underway to look at whether to give those more routinely. It's really important to say that about 40% of people so far affected in the UK have been people living with HIV, and certainly for people living with HIV who are on treatment, there is little or no evidence that the course is any different. That's not absolutely conclusive, but it is looking like there is not a very significant difference. And perhaps important to note that people have to isolate until all the exposed skin lesions have healed and the scabs have fallen off, and that's because the scabs contain quite a bit of monkeypox virus. I'll leave it there and let colleagues, I think Colin's first, take over and add further information. Thanks.
Thanks, Dan. I'll just check that you can hear and see me before I continue. Okay, great. Well, my name's Colin, and I'm an NHS consultant in public health or health protection. My pronouns are he, him, and I work for Public Health Scotland, and we are leading the response to the current monkeypox outbreak as the National Public Health Agency. So public health, we tend to deal with populations and larger groups of people and look at how an infection is spreading through society, whereas my colleagues Dan and Daniela, they'd be the doctors that you would see if you went into a clinic on a one-to-one basis. So we're not often seen, but we're there doing the epidemiology and also coordinating responses like vaccinations and trying to understand how transmission is happening and trying to put in place ways to stop that. So I'm just going to cover a bit about the epidemiology, which is basically just what the pattern of infection looks like in the population. And I'm going to talk a bit about what some of the public health responses might be that you may be involved with if you were a contact or a case of monkeypox. Hopefully not, but just try to explain what the situation would be. So epidemiology, we talk about person and place and time, and Dan has mentioned some of these things. So we're looking at what are the groups of people affected, where are they, and are the numbers going up or down over time. And I just say we have really excellent epidemiology in Scotland, and it's really fantastic, the amount of detail that we can understand about situations now. So in terms of person, I think you all know that the group most affected just now is GB-MSM. So from our interviews with cases, we know that in 99% of cases are in men, and that 95% where sexual orientation is known are in GB-MSM. Women and children have been tested for monkeypox, mostly as named contacts, but primarily as household or workplace contacts. So it's not because of a bias in who's being tested that this group of GB-MSM are found to be more at risk. It is likely to be truly that that group is more at risk. In terms of place, the outbreak has been very focused on London. About 2/3 to 3/4 of cases have been associated with London, and not just to do with the population there, but that is also likely to be where most of the transmission has occurred. That is falling now, and it is more associated outside of London as well now, and also been quite associated with travel outside of the UK to Europe. In Scotland, every area of Scotland has had a case, but we know that the cities where larger populations are have been more affected, in Glasgow and Edinburgh in particular. And in terms of over time, the trend is uncertain just now, but we haven't seen an explosion in growth in cases. Numbers seem to have stabilised recently, and this is tentative and a lot of uncertainty. And the difficulty is knowing whether that's really due to the slowing down in the spread of cases or any reluctance to come forward for testing. So whether it's a true finding, as I referred to before, or something that is an artifact of something else. So it's not over by any stretch of the imagination, but it is positive indication. And these findings are the same across Europe. The epidemiology that we're seeing in Europe is very similar. I just want to thank everybody who helps to put that data together, in particular the participation of people who speak to health protection teams when they're phoned, because all this data relies on people engaging with public health, and our completion on these questionnaires 100% so far. So just a note of thanks there. There's some sources of information that I'd like to ask you to rely on if you do want to look for more information on epidemiology. The numbers are on the Public Health Scotland website, and we'll put the link in the chat. There's very detailed epidemiology on the UCSA website, which is the UK Health Security Agency, who cover England, but we work in collaboration with. And there's a technical briefing available there, which I'll also post, which goes into great depth. And there's also global information available, which we'll post. Just a note of caution on trusting Twitter or social media experts unless they have clear credentials that are in their bios. A lot of people have a lot of things to say about infectious disease, and COVID has only increased that. So just a note of caution. So I'll just rush through, if I can, through what might happen if someone gets monkeypox in Scotland from a public health point of view. As I say, from a clinical point of view, you would go to a sexual health clinic or to your GP, and you would see a doctor or a nurse, Dan or Daniela, and they would look after you as an individual. But in public health, we also want to try to stop any further onward spread of the infection. And we also want to know about how the infection has been spreading. So if you are a contact, it used to be very hard to explain what contact tracing was, but since we've had COVID, it's become pretty easy. You've probably all had some engagement with contact tracing. It's basically trying to find people who've been in contact with someone who might have or who has an infectious disease so that we can give them a heads up and give them a warning about the risk to them. With monkeypox, we're not talking, as Dan said, about everybody. It's not like COVID in that sense. We're talking about people who might be at risk. So we're talking about sexual partners, the people that you live or share a bed with to a lesser extent. And it's mostly sexual partners, and it's much less about social contacts or passing contact. We're only trying to get in touch with those people who might be at risk to let them know. I should note at this point, this has been really challenging with monkeypox, and we're having difficulty getting named contacts and identifying contacts. So one of the messages I hope that you will take away from this is to share the message that contact tracing is anonymous. We hold all the data. It's all done by NHS professionals, nurses and doctors working in health protection teams. They don't pass on the contact details to the contacts who are named. And it's all based on the person who has the infection sharing that information. And the reason for doing that is to help contacts understand any risk that they might have. We're not asking contacts to isolate, because if onward transmission isn't just them going about their daily business, we are asking them to avoid undertaking the activities that we think might be implicated in transmission, which is intimate and sexual contact or close skin-to-skin contact for 3 weeks after that contact. So we don't say stay at home, don't go to work, don't do anything like with COVID where we said, we just say try to minimize and we'll go on to talk a little bit more about some of those bits of advice. Contacts might also be offered vaccination if they're named. Post-exposure vaccination is what we call it, and it is not so much to stop you developing the infection at all, but to minimize any symptoms if you did develop an infection as a contact. If a contact has symptoms, you really should get tested, and that's the main action for a contact, to monitor for any symptoms in themselves. And as Dan says, might be what we call a prodromal period at the beginning, flu-like symptoms, feeling run down and tired. And if you knew you were a contact, you might have that elevated thought in your mind, or it's not just that I'm feeling tired from work or whatever. You might think, I should go and get tested with these symptoms. And the health protection team would explain all the symptoms to look out for. But if you haven't been named as a contact, you haven't been told you're a contact, you might miss those. And that's why contact tracing is very important. It might be that you're told by someone that you're a contact of them and that they have monkeypox, but that they haven't been tested. Or they might say, oh, I didn't name you when I was asked because I didn't think you would want me to. In those situations, we'd really like you to encourage that person to go to be tested if they say they have symptoms. That's the best way to help them. And if they say, I didn't name you as a contact, but you know you are a contact, the best thing is to ask that person to go back and name you as a contact. That way, they get the help that they need, and you get the help that you need. If you're a case, I think we've talked about the clinical care, going and speaking to sexual health clinic, and you get all the medical help that you need there. In the public health point of view, for the case, the main thing is that just one point to make about there's no shortage of testing available. So testing is freely available to everyone, and there's no limitation to the testing that can be undertaken. If you have symptoms, if you're a contact in particular, please come forward for testing. Don't think that there's any shortage of that. If you are a case or you have symptoms as a contact, you should start to isolate straight away and ring in rather than visit the sexual health clinic without ringing first. And if you're a case, we do ask you to isolate because we know that you have the infection, potentially infectious to others. And we ask you to not have sex with others and also to isolate from within the household as well, where possible. And Dan has mentioned, monkeypox is a disease that affects animals as well. So we also ask people to stay away from their pets. We know we're asking a lot here, and help and support is available. So Waverley Care, who are here with us, will come on to that. But the health protection team can also help you, including with support if you have to isolate away from work. They can arrange to help you in that situation. I just want to finish really on saying that we know we are asking a lot of cases and contacts. It's not an easy or straightforward request, but it's doing the right thing to help others and to try to stop or slow the spread of this. And we really do believe that spread is slowable and stoppable. The vaccine will build on our response, but it can't be the only thing that we rely on. We have to have these other health protection measures as well. So hopefully that has explained some of the questions that you might have. But I think if you paste them in the question box, then we'll come to them afterwards. I'm just going to pass on to Daniela at this point, who's going to talk about vaccination and the vaccination programme, which is a critical element. Thanks.
Hi, thanks, Colin. Can everyone see my slides? Yeah, perfect. So my name is Daniela Broley. I am a consultant in NHS Grampian in sexual health and HIV, and I also co-chair a group of clinicians which come together across Scotland to discuss best practice. And obviously we've been having quite a lot of emails recently with monkeypox, trying to manage cases coming through, and also the vaccination programme. And I also answer to the sexual health wifey, which I'm known as up in the northeast of Scotland. And my pronouns, are she and her. So, sorry, I'll just try and put this on. So, what is the vaccine for monkeypox? Well, I think in a way it's useful that we've had a pandemic, another outbreak of infection where we actually have a vaccine which is hopefully almost readily available, unlike COVID where we had to wait for quite a while. So there is the smallpox vaccine which is available, which we think has quite good cross cover for monkeypox. There's still being obviously further trials being done because of the increase in the number of cases. A lot of the trials done previously were very small numbers of individuals. So we're hoping that obviously works well. The good thing about it is it's a third generation vaccine, so there's less side effects than the previous smallpox vaccinations. However, they were still used very widely in the population. It's slightly confusing in that it is called, if you look up the sort of information about the vaccines, it does say it's a live vaccine, but it's actually replication deficient. So it means that the virus in the vaccine has been changed so many times that actually it doesn't have the genetic tools to be able to make new copies of itself. So it's very safe for pretty much everybody to take, and it still mounts, we hope, a good immune response to the virus. And there's two different types, and basically they're basically the same. It's just different companies that make them, and their names are there: Invenex and Jynneos, and they are interchangeable. So we do recommend that people get 2 doses, and it might be you get one Invenex first and a Jynneos next, and that's okay. It's a bit like COVID, getting different brands of vaccine is okay. The only time we would recommend that people have 1 dose of the vaccine is if they've had smallpox vaccine already and they're not immunocompromised. So if you are lucky enough to be born before 1971, you may well have had that vaccine, and that will be asked for anybody who presents for vaccination. We take a vaccine history from everybody. So how well does it work? It works, pretty well against smallpox. There, as I said before, there are ongoing trials, but so far so good. It's looking like it's a pretty effective vaccine, but we will need to wait the outcome of formal and larger trials to be sure exactly at what level that effectiveness is at. As I said before, it's 2 doses. However, we will come on to the fact that just now we are focusing primarily on first doses, and that is obviously because of vaccine supply and trying to get as much coverage as possible, exactly the same as what was done for the COVID pandemic. There are limited evidence about how useful it is for post exposure. However, it is given, as Colin said, it's better, like anything that's given in a post exposure situation, it's better to be given as soon as possible, but can be given up to 2 weeks. And again, that's something that it is important to potentially take away from here. One of the things about preventing onward spread is potentially sharing contact details more with partners, if you feel comfortable doing that, in order to make you obviously more make it easier for people to get in contact with contacts if they are eligible for post-exposure vaccination. One of the things that people often ask about vaccinations, and again has been much more in the media recently over the last few years, is about vaccine safety. So as I said before, it is a safe vaccine. The traditional smallpox vaccines were used widely in the population, and this is an even safer vaccine as a 3rd generation. It's non-replicating, so it's not technically a live vaccine. It's similar to other vaccines in that sometimes you can feel a little bit rubbish afterwards. So you might have a bit of a sore arm, a bit of redness or swelling, and also flu-like symptoms. So that could be anything from headache to fever, feeling tired for a few days afterwards. And again, different individuals will respond differently to vaccines. We do have a caution about individuals who have atopic dermatitis. It doesn't mean that you can't have the vaccine, but just a caution that you may be more likely to have a reaction to the vaccine, or that your dermatitis might get a bit worse, particularly if it's severe. However, I would say that if you have that condition, please still present for vaccination if you're in an eligible group, and we can have an informed discussion with you, with the clinician who is vaccinating you. There are some cross-reactivity with other allergies, and we have to be cautious, particularly if somebody has had a previous severe reaction or an anaphylaxis with several different types of antibiotics, and also chicken or eggs. But it would have to be a pretty severe allergy anaphylaxis for us to not give it. So again, if you fall into that category, please still present for vaccination, and that can be discussed on an individual case-by-case basis. And again, pregnancy and breastfeeding, it's a balance of risk, but again, if somebody's at risk, we would say it's better for them to have the vaccine. So who is eligible? Well, this has very much been based on epidemiology and may change in the future, but currently what we are advising is gay, bisexual and other men who have sex with men, so GBMSM, including transgender men obviously, and transgender women who are either prescribed PrEP or have been prescribed PrEP, or who are PrEP eligible and perhaps have declined, or are living with HIV and therefore don't need PrEP. And that includes things like having multiple partners, with unprotected sex, and also a recent bacterial STI. The other risk factors include attending sex on premises venues, planning to travel with sexual contact with new partners at that destination, or there can be other groups or risk behaviours at clinician discretion. And as Colin said before, contacts, depending on what type of contact that was and the history, can get post-exposure vaccination, and healthcare workers, but that's quite a strict criteria, healthcare workers who are either involved in directly testing cases or in treating individuals who have tested positive. So accessing the vaccine, the vaccination programme in Scotland is being delivered through sexual health services in the vast majority of areas, apart from post-exposure, which may be done through other settings. And sexual health services are actively contacting individuals who they know are eligible. However, I would say if you're new to the area, if you've moved from a different health board or from another area in the UK or abroad to Scotland and you feel you're at risk, and you're not known to services, or you've potentially just not used services in the past, then please do present so that services can add you to their eligibility list and try and get you an appointment. NHS Inform has a list of all sexual health services in Scotland, and also third sector colleagues can signpost you or help you access services, or can help negotiate that if you feel that accessing services as it hasn't been a good experience, or that you feel there's barriers to you accessing services. So the Scottish programme so far, there's been quite a lot of media coverage of this over the last few days, so you may well have seen it, but the Scottish programme is up and running and has been for the last few weeks. We've currently been allocated 3,000 doses for an estimate of over 6,500 individuals. That is a very crude estimate. It could be higher or lower than that, depending on the additional amount of individuals who don't access services, and obviously also vaccine uptake. Approximately 800 doses have been given so far. It's probably slightly more than that because there can be a lag time between getting that data collected across services. And the thing really to emphasise currently is that there is a limited supply of vaccination, because there is obviously a real peak in global demand, and areas with the majority of cases are being prioritised, and that's not just within Scotland or the UK, that's also internationally. So although we may require 7,000 vaccines currently, we only have 3,000. However, services are planning to give all of the allocated doses by the end of August, and there is further doses expected to be delivered to Scotland in September. So hopefully there shouldn't be too long a wait in terms of get between now and getting all of our cohorts vaccinated with the first dose. However, there may well be a wait for several weeks for individuals to be able to access the first dose of the vaccine. So there are different things that people can do to keep themselves safe. And I think Alan and David are obviously going to discuss this in a bit more detail, but there's just some pointers here that potentially we can go into in a bit more detail, either as I say, in Alan and David's chat, or with questions at the end of the presentation. And I'll just stop sharing my slides there and pass you over to Alan and David.
Hi, David here. It's a one-man show. Alan's in the audience somewhere, so I'm just going to kind of do a wee update. I think quite a few of the speakers there have talked about some of the kind of symptoms associated with monkeypox. And when we're talking about prevention, I think it's really, really important to think about some of those symptoms. So monkeypox is not necessarily seen as a sexually transmitted infection. So just being with someone, laying next to them, skin to skin, you can pass on the virus. So it's not necessarily about having sex, it's about being in close contact with someone. We would always encourage the use of condoms, but condoms will not protect you from monkeypox. And we will also in terms of preventing other STIs and HIV, would ask you to continue taking your PrEP as well. So it's about being observant. It's about if you have a date with someone, if you're going to a venue where there's sex on premises, if you're meeting somebody online or on an app, and you're with that person, it's about just being consciously aware, I think. And if someone is presenting with kind of a rash or spots, then it's really, really important to take note of that. But it's also important to be kind. So if someone that you're having sex with or someone that you meet has spots and they're not even aware of them, it's not about being outraged and it's not about attacking that person, it's about being kind. It's about sharing information. It's about if you've had sex with someone and that person contacts you and tells you that you know, they've been diagnosed recently or they're presenting with symptoms, it's about then you taking some control. And it's about thinking about your own health and your own symptoms, but also maybe kind of booking in for a test as well and get yourself checked out. And while you're doing that as well, do avoid having any kind of sexual contact or physical contact with someone else, because before you're tested, it might be that you're carrying the virus, and it might be that you could pass it on to someone else as well. It's also about, in terms of bedding, towels. So if you're having sex with someone or someone comes to your home and is sleeping in your bed and that person leaves later on or in the morning, it's about, changing the towels. It's about changing the bedding. So it's, again, like I say, it's about being really, really observant. And if someone, like I say, gets in touch and say they've been unwell and they kind of think they've got symptoms, to take that on board. This could be monkeypox. It might be something else, but like I say, it's really important to kind of be observant. So yes, it's about being kind to others. It's about looking after your own health, but also looking after other people's health as well. And I'll leave it there, and I'll pass you on to, who am I talking to? So I'll pass you on to Christopher.
Thanks, David. Yeah, so I'm Christopher and my pronouns are he, him, and I manage Waverley Care's Gay and Bisexual Men and All Men Who Have Sex with Men service. And I'm going to be just talking about where you can get some further information and support. So I already believe there is a link to the NHS Inform page on monkeypox, which I'll talk about in a second. But I thought I wanted to start off with just 2 points to begin with. And Colin's already made this one, but it is worth repeating, is that to make it clear that there is a need to act on information from trusted and reliable sources. So think about where the information is coming from. And particularly in Scotland, we're thinking about the NHS, public health, and the third sector represented here. The second point is that the situation can look quite different from country to country as well. So ensure that you're looking at Scottish specific information from the sources I've mentioned. Now, the NHS Inform page that is linked below, there's lots of vital information in there that's been covered already. So it's gone into kind of symptoms, how monkeypox can be transmitted, ways that you can reduce transmission, including information relating to sex and transmission. It's got some more information about treatment, but as well information about the vaccine and vaccination program as well. The thing to be mindful as well is that there's also FQAs specifically designed for gay and bisexual men and all men who have sex with men. Now, these question and answers have been done in collaboration between the third sector, the NHS, and public health, based on questions that we were asked from the community, and also key bits of health information that we think are necessary for people to feel informed and be able to make informed decisions about their sex and their health at the moment. So these FAQs can be found on websites that include Terrance Higgins Trust, LGBT Health, HIV Scotland, and Waverley Care, and Waverley Care's Gay and Bisexual Men's Service, SX. So you can access further information from the organisations that I've mentioned, and as well, you can get advice on your specific situation from local sexual health services. So I'm thinking specifically in relation to vaccination that Daniela had mentioned earlier. And in terms of the support, there's the support element that Waverley Care provide for people that are self-isolating due to monkeypox. So this is done as a video call or a phone call during the period of someone's isolation to help them manage that situation and the isolation and the mental health problems that may come with that situation as well. And also be mindful that if you do have questions and then you do want to learn more, or just kind of pick apart a few things and see if you can have more specific tailored information to your situation, the third sector, NHS, and other sexual health services are there for you as well. But have a look through the NHS Inform page that's attached. It's got a specific link around vaccination and also monkeypox and sex. But I think now I'm passing on for questions, if I'm right. I can see Mark nodding, so that's hopefully correct.
Perfect. Thanks, Christopher. And thanks to all of the panelists for your presentations and for the information. And thanks for those in attendance who've been putting their questions into the chat. If you've been following the question and answer window, you may have seen the questions reduce. We haven't blocked or deleted any. As we've answered them, or some of our clinical colleagues have answered them as we've gone along, they move over into another tab. So at the top of that box, you'll see open, answered, and dismissed. So you'll be able to see those there. So a couple of questions came in about, given the population and concentration of cases at the moment, will the vaccine only be available or targeted in cities and densely populated areas? What about Shetland and rural areas? And our clinical colleagues have responded to reassure us that the vaccine is available in all board areas, including the Highlands, and to contact your local service and they'll be able to advise you. There was a question about why anybody can get monkeypox, or why are these messages and these sorts of events targeting gay and bisexual men and other men who have sex with men? Thanks, Colin, for answering that's factually accurate and confirming that actually the very large majority of cases at the moment are in our community. And so we have a responsibility to try and look after each other, which is why we're targeting messages at those people most proportionately affected at the moment. And we'll come on to the questions that haven't yet been answered. So this is probably one, I think, on the back of your presentation at the beginning. I think, Colin, the advice was to isolate until all scabs have fallen off and healed. Any idea roughly how long that would take? And I guess as a follow-up question, anything people can do to speed that process up?
Yeah, I must say I was delayed on that one, hoping that Dan Clutterbuck will come in on it. But my understanding is it's 3 to 4 weeks from what we've seen from cases so far. And Dan, you may want to add something. There's 2 stages of de-isolation. There's one once all of the vesicles or the pox that is non-visible, that can be covered with clothes. If you can cover them with clothes, you can de-isolate to leave the home, and then I think there's a longer isolation period for any pox or vesicles that are unable to be covered by clothing. But I think the simple answer is 3 to 4 weeks. And Daniela or Dan, please correct me if I am under or overestimating.
Hi, yes, thanks, Colin. I was going to pick it up, but you've covered it very well. So yeah, I'd say 2 to 4 weeks. And also, of course, it does depend when people present and get tested, because sometimes they've had the lesions for a while. So not everybody who comes and gets tested then has to isolate for that full period. But certainly we've been finding between 2 and 4 weeks. If people have very a more severe case of monkeypox, it can take longer. There's no getting away from that, but that is a small proportion of cases. And as Colin said, the isolation, the initial phase where people have to isolate completely applies to lesions on the face and hands that can't be covered. And once those have healed properly and the scabs have dropped off, even if they still have lesions on their trunk or on their genitals, they can, they don't have to isolate in the home, but some people would then be restricted, for example, from contact with pregnant women or people who are immunosuppressed. And some people might be restricted in terms of work, for example, if they worked in healthcare until all the lesions, including the covered ones, were healed. I hope that's clear.
Great. Thanks very much, Daniel. So we have a question from somebody who's been shielding for COVID. So who are allowed to get the vaccine and what might they do if they're still shielding?
Would you like me to come in?
That would be great. Thanks, Daniela.
I suppose it's about a sort of balance of risk. So if somebody's shielding, then they may not be at risk of monkeypox if they're not meeting up with partners. So I think it would be a discussion, a sort of one-to-one discussion with that individual around if they're shielding and they're not at risk of monkeypox because they're not putting themselves at risk, or be it meeting up with people, then it might be that they don't need to travel for the vaccine. But if they are, then obviously there are things that the clinic can do. So for example, back during COVID, if anybody was shielding for any reason coming to services, we would see them first thing in the clinic. They would be taken straight into the clinic room, not being told not to sit in the waiting room, etc. So there are things that services can do if individuals feel that they're at risk.
Thanks, Daniela. And we've got some questions coming in, people apologising if they've missed something. That's absolutely fine. We've thrown a lot of information at you this evening, so please do ask questions. And I've been watching the participant numbers increase as we've gone through as well. So if you've joined late, we can repeat some of the information. And we'll talk at the end. Alistair will speak in a minute about how you can access some of this information and rewatch this video this evening as well. Can we stick with yourself, Daniela, on the vaccine? Somebody is asking, this is about testing. Will individuals be contacted, or should a person who believes themselves to be eligible or vulnerable contact their local sexual health service? Hearing from friends in London that supplies are low. Could we just revisit that, please?
So, and is that regarding vaccination? Sorry, you said. Yeah.
Yes. Yeah.
Yeah. So, So services have obviously a list of individuals who would fulfill the criteria as best we can from our clinical systems. So not everything that is within the eligibility criteria is easy to extract from our clinical systems, but some things like PrEP prescriptions, STIs, other things are. Services are proactively contacting individuals who are eligible. However, if you feel that you've not been contacted, or particularly if you've moved areas, or you've never used your local service because you've maybe accessed testing in other ways through your GP or private providers or third sector, then I would urge you to contact your local service so that they can assess you and add you to the list of individuals who are waiting to be vaccinated, or they may indeed offer you an appointment right there and then, depending on their vaccine supply.
Great. Thanks, Daniela. Sorry, as people are typing the answer to questions, it's moving around my screen, so apologies for the confusion there. This is the question on testing. Is testing only done through swabs of lesions, and how long are people waiting for results?
I can pick that up if you want.
Thanks, Daniel.
So most testing is swabs of lesions. There are other, we do sometimes do testing in other ways. For example, swabbing the throat, and occasionally on urine, and very rarely on blood. But in most cases, as we said, about 95% of people have a rash. So we would usually test from spots, but we can make a decision in each case. And as has been said, there's no restriction on testing. In terms of the turnaround, we're really lucky because the only lab outside London that set up monkeypox testing was in Scotland. So we are at best getting turnaround in about between 24 and 48 hours. And allowing for transport within Scotland from other labs, it might be a few days. But we're expecting results within days, and sometimes only a couple of days.
That's good news. Thanks, Daniel. We've got one more question listed at the moment. So if you have a question that you've been thinking about asking, there's plenty of time, please do so. We have a colleague from the NHS online who said he'll stay off camera unless there's a Nikki-shaped question and answer that comes in, and this Nikki might be a Nikki-shaped question and answer, although Colin might be happy to take it as well. There's a lot of gay men that are referring this back to, or being reminded of the AIDS and HIV crisis. Is there messaging that we can get to this part of the community, especially if they've been vaccinated for smallpox before, to put them a bit more at ease?
Hi, yeah, I'll take a little bit of this. Hello, I'm Nicky Coya. I'm Health Improvement Manager for Sexual Health with NHS Greater Glasgow and Clyde, and I use he, him pronouns. So I think it would be good just if in people's networks, if they're able to share information that they've got from tonight. So check the NHS Inform website, as other speakers have said, but I'm also very pleased that the Scottish Government has now provided funding to develop a very targeted social media awareness raising campaign specifically for gay and bisexual men and other men who have sex with men who are more likely to be in sexual networks where monkeypox is present. So we started working on that with various community organisations and with Public Health Scotland and Terrance Higgins Trust, particularly where Dave's from, are really helping us do that because they have a really good track record of that. So we've got some very targeted information which will be going on through social media, through some of the cruising and dating apps, and yeah, so that's I guess our plans around the messaging. And I can completely, going back to the question, I can completely understand why I think for those of us who have a certain age, there's a resonance around what's happening now with the early days, particularly of HIV. But I think when situations like this arise, our communities, I think, are often the best response. They bring out the best in us as a community. And I can see that that's already starting to happen here in Scotland.
Thanks, Nikki. Colin, would you like to add anything to that, or are you satisfied with that response?
I think there's people better placed to talk who've got a lot more experience of the HIV epidemic than me. If they want to add anything, I wouldn't suppose to add anything other than what Nikki said, except to reiterate the messages that have been: this is not HIV. We're not dealing with something that is on the scale of HIV of the severity. Dan mentioned the symptoms, the resolution, and the relatively mild cases that we've been seeing, very low hospitalisation, and no deaths in the UK. So just to say that it's not something that I would say we're dealing with on the same scale. But from the response and the media response, I can see the similarities. And just to reiterate, the public health position is that we're not targeting this at one group of people for any reason other than we want to provide the support where we're seeing the cases. The aim isn't to stigmatise in any way. It's just to provide support where we think it would be most useful.
Great, thank you. And I know I'd received an email this morning from the LGBTI equality team at Scottish Government, forming a roundtable to talk specifically about communication strategy at government level as well. So there'll be various pieces of communication targeting various parts of the population in numerous ways around this. So thank you for that question. I don't have any other questions waiting in the Q&A box at the moment. There is about a 1 minute delay, so I'm just going to have an awkward silence before we hand over to Alistair to sum up and finish off in case anything else comes in. We've got one, thank you. Justifies the delay and not too awkward a silence. The childhood smallpox vaccination, Daniela touched on this very briefly. Does it offer any protection?
Yeah, we think it probably does. So for individuals who are not immunocompromised, then they would have one dose of the monkeypox vaccination as opposed to two. So it should give people some protection. We don't know exactly how much, but there is a theory that you would have some protection from that initial dose.
Okay, thanks, Daniela, and thanks for the question. Just do that awkward silence for the delay. Alistair, this is time to warm up your vocal cords.
Play nice. Just to thank everybody really for what has truly been a coordinated response. It's been really encouraging as a newbie at HIV Scotland, I guess. I'm pushing my luck saying it's a year, but it really has been a consolidated and a coordinated response. So thanks to Mark for great facilitation and Nikki Coyer for championing this webinar and the campaign that's just about to hit you imminently if we get up to speed with it. But I think the planning is certainly in place. And thank you to NHS, Public Health and Third Sector colleagues for what I think has definitely been a rich discussion. I hope the people that have enjoyed it online can go and enjoy the rest of the evening in the sunshine. But thank you all for engaging. I think it's been a very rich discussion for us all. Thank you and good night.